you very much. Okay. Well, gee, following Steve Jobs, that's a tough act to follow, and I want to thank the organizers for allowing me to speak, especially with all my esteemed colleagues. So I might as well start here with a picture of this stadium. And why do I show this? That in the year 2050, it's been estimated that 1 out of 3 individuals in the United States will have diabetes. And we know that a large percent of those will have type 1. We talk about the explosion of incidence and prevalence of type 2, but if you talk to the type 1 diabetes therapy guys in clinic, they'll tell you every year the prevalence and incidence is increasing. Now, I want to tell you about myself a little bit, which sort of relates to my topic of extreme diabetes makeover. So I hate to show pictures of myself because it's pretty embarrassing, but there I am in high school. I came down with type 1 diabetes. I was thirsty. I was falling asleep in class. My teacher reprimanded me for having to go to the bathroom once or twice during that hour. The kids behind me in line were yelling at me because I could not quench my thirst. And thinking back, you know, it's really important that I think the public gets educated about diabetes to help wipe out some of this ignorance and intolerance for sure. Well, here's a picture of me when I was a counselor at a boys camp, the Griffith Park Boys Camp in LA. And this slide reminds me to tell you a couple things. First of all, in 1970, there was no glucose meters, no A1C test, which tells us how patients are doing in the clinic over 3 months. There was no fancy insulins, there was no pumps, there was no pens. And diabetes care was pretty archaic, and all I had was my little urine test kit. And I remember going to class, diabetic class, 49 people who were overweight with type 2 and myself, a skinny, naive teenager with type 1. And I do remember one thing from that class, I'll never forget it. Ketchup has a lot of sugar in it. And don't ask me why I remember that. Now, I used to go to my doctor who didn't know much about diabetes. He was a great guy, but he knew nothing. And back then, they really weren't that serious about treating patients. And I'd go to his clinic, and every time I go in, he'd say, "Steve, you're doing fine, see you next time." And all he had to look at was my blood test that day and my urine record, which of course I falsified. And so as I got older, I knew my control was poor. I was urinating, I was thirsty, my cuts on my knee would not heal. And so I decided to test him. And one day, on the way to clinic, I went to Winchell's Donuts, and this is a true story, I ate 5 donuts. So I checked my urine in the bathtub at the clinic, in the bathroom. The little strip turned dark in about 2 seconds, meaning my blood sugar was really high. I drew my blood, he comes in the room, he has a clipboard, and he looks at me straight in the eye. And like every previous visit, he said, "Steve, you're doing fine, I'll see you next time." So you know, that may be funny. It sounds funny, and people laugh when I say it. But there is the bad part of the story, which is I've had complications. This is what it looks like if you have a vitreous hemorrhage, sort of what it looks like when blood goes in the back of your eye from the arteries in the back of your eye become damaged from chronically high blood sugar. And you know, in these classes, back then, I'm thinking as a 15-year-old kid, there has to be a better way to promote education. You know, one size doesn't fit all. And I'll tell you what, I'm sure they told me high blood sugar leads to complications, but it was never told to me in a way that really sunk in, where I actually understood it. So I went to medical school and at UC Davis, and I remember in the nephrology class, the kidney class, the professor gets up there and says, 50% of all type 1 diabetics die 20 years after their diagnosis. And I'm sitting there and my friends are looking at me, you know, and I'm trying to act pretty normal, you know, and my best friend, Ken Factor, he said to me, he's a jokester, he said, "Steve, at least you know what you're gonna die from." And even in that time period, I realized that you know, there has to be a way to improve the health of people living with diabetes. I went to the Joslin Clinic, there's me, and I learned there, it was a great institution that, you know, you have to get patients to put diabetes higher on their priority list for sure. So I came to UCSD and became a faculty member. And at that time, in 1993, one of the most famous studies in type 1 diabetes was published, the Diabetes Complications Control Trial. Make a long story short, it took a 9-year, $160 million to prove once and for all that if caregivers go through the hassle of improving the blood sugars in their patients, they will have less eye, kidney, and nerve disease. But the problem was that I didn't think things were happening fast enough at the community level. And I thought this publication was really going to change the way we treated diabetes rapidly. And so there were lots of reasons why the results of these important clinical trials were not being implemented at a community level. So managed care was beginning to hamper the way we take care of patients. It's still here. I hate it. And if you really want me to use some cuss words, Jen, I can start talking about managed care. As a caregiver, totally helpless within the system. And this is a key point. There was very little education directed to people living with diabetes. And if you look at the traditional education model, first of all, it takes, on average, 12 years to develop a drug and get it past the FDA, $2.3 billion. Then you have the research and teaching institutions that are supposed to educate the caregivers. And we know that once you graduate your professional school, it's really tough to change your practice habits. And then those caregivers take care of the people with diabetes. It's very slow, it's very inefficient, and we really have to change that model, and I have a suggestion at the end of my presentation. So it dawned on me that we really have to take the most important messages about living a healthy life with diabetes directly to the people most affected by it, people living with diabetes. So in 1995, I started this not-for-profit organization called Taking Control of Your Diabetes, and I realized at that time, which I was just going to do one a year, I already have a couple other jobs, but I realized people were thirsty for information. And this became a national organization. And we have our next conference coming up November 12th. Now, when you get people with diabetes together, a couple things happen. For once, they're in the majority and not the minority. And they also realize that diabetes crosses all socioeconomic, ethnic boundaries. And I think that's really quite important. You know, we get people together and we push these main messages. It's all about education, motivation, and self-advocacy. You could have the best researchers in the world, the best therapies, but if someone doesn't put diabetes on their priority list, if they're ignorant, if their doctor is not up to snuff, then it doesn't matter. And I think this is where the rubber meets the road. You know, our success is built on uplifting messages with well-defined and attainable goals, and addressing the emotional barriers. And I learned that from my good friend, Bill Polonsky, who will be speaking in a few moments. And I'm a big believer in humor, not just because I'm a big jokester, but because I think humor improves information retention. You know, and I wish some of my professors in medical school, undergraduate, you know, had a sense of humor. I might have remembered something more than sugar and ketchup. So we've come a long way in diabetes. I mean, this is a sad picture. This is not that long ago. And I like to show this to animal rights protesters, you know, where we learned about diabetes and discovered insulin from dog research. And if you're a parent of one of these kids, you know what you were told to feed them? 500 calories a day, Monday through Saturday, and then Sunday, nothing. And they either died of starvation or a metabolic derangement called diabetic ketoacidosis. Now, what are some of the advances available to people with diabetes? I'm not going to go through this list, but there have been a tremendous list of advances. We have pens, designer insulins, insulin pumps, meters, continuous glucose monitors, software programs. We really have the tools now to keep people healthy until a cure comes along. But the problem is, despite all these advances, if you look at the national statistics, the percent of patients who have adequate glycemic control, not just an average blood sugar or hemoglobin A1C within goal, but reductions in fluctuations, really high and dangerously low. So we still have a lot of work to do, for sure. Now, I want to go through some of the lists of at least what I think is some of the main issues, and there's a lot more than this list I'm going to show you. You know, this is more of a clinical scientific area, but the way we give ourselves hormones like insulin and Symlin, it's very unphysiologic. When our organs and our body secrete hormones, they go right into the bloodstream. They work very quickly. And this unphysiologic way of delivering these hormones lead to unpredictable fluctuations. And that's a big frustration for people with type 1 diabetes. Hypoglycemia and fear of low blood sugar. This is huge. Once someone passes out at work or driving their car, getting in an accident, it's really tough to get those people near goal. And this is a big area of concern, especially since we want to keep the blood sugars down and avoid complications. Emotional behavior barriers. You're going to hear that from Bill Polonsky in just a second. And patient and professional inertia. I can't tell you how important this area is. Patients, I've never met a patient that doesn't want to live a long and healthy life, but diabetes is not high on their list. And so they'd rather take a vitamin down the street in the vitamin store. They don't know what the heck's in it, but they won't because it's natural. And I tell them, strychnine's natural. But they won't take things that are proven to be safe and effective by the FDA. And we talked about professional inertia. It really bugs me. Not only do physicians don't keep up with medical information, but they think they know it all and they don't offer these new technologies to their patients, for sure. Now, a lot of patients say, gee, I don't like testing my blood sugar. Who likes pricking their finger? And they say, I don't like carrying my, anything with me, so they don't have their insulin with them. Well, I can tell you right now, I am wearing 3 insulin pumps. I have a Symlin pen, I have an insulin pen, and I have 2 glucose meters with me. And do I look bogged down? You have to, you want to get diabetes so it becomes just like brushing your teeth every day. And I think that's the key. And this is what we do at Taking Control of Your Diabetes, and I think what we need to do around the country with any organization. We need to offer individualized and culturally sensitive patient education. I mean, if we don't do this, we're not going to make a dent in improving diabetes care in this country. That's for sure. And of course, poor diabetes care. Uninformed caregivers, not stupid caregivers, not ignorant, just ignorant, not keeping up and not knowing enough. And then of course, bad healthcare policy. I say all the time that diabetes is not a rare disease and it's not an inexpensive one. So I speak to HMO executives all the time, trying to talk them into allowing patients to have the better insulins, the continuous glucose monitors. They sit there like this. They turn red in the face. They're usually wearing a 3-piece suit. Oh, sorry. And I really want to tell them off. And I want to give them a gesture. And the only gesture I could give them is this one right here. When you talk about kids, you can get away with almost anything. So what about the title of my presentation? Extreme Diabetes Makeover. And I want to show you a program that we did at Taking Control of Your Diabetes. It's a reality-based documentary where we screened people who wanted to be in the program. You had to have 2 requirements, just 2. Your diabetes had to be really messed up, and 2, you had to have the desire to get better. And you know what? We didn't have any problems finding these folks. These are people just walking around the community with diabetes, really good people, but really poor control for one of several emotional, physical, financial barriers. And we exposed them to a dream team of specialists, myself as the diabetes doctor, Bill Polonsky, as I call him, the touchy-feely guy, a dietitian, an educator, and exercise physiologist. We saw them weekly for 5 months. And we got their control under extremely good levels. And people have said, the program's over, what happened to them? Guess what? They're all maintaining their control because now they're doing it for themselves primarily and for their caregivers secondarily. And I think it comes down to this slide. It's about becoming activated. We're getting educated, motivated, really take control of your diabetes. And that's where the rubber meets the road. Now, I want to show you I'm going to show you 2 of our participants. This guy is unbelievable. His name is Tim Smith. I've gotten permission to say his name. He's a lawyer. I don't really like helping lawyers, to be honest with you, but I did make an exception in this case. And he has excellent health insurance. He has the highest level of education of all the 7 participants. He got diagnosed with type 1 diabetes later on in life called LADA, latent autoimmune diabetes in adults, and he's on multiple daily injections. He wasn't testing his blood sugar, and he was seeing one of the most prominent endocrinologists in San Diego. Yet his A1C was 11%. Now, for some of you that don't know what the A1C means, it tells us that his average blood sugar was well over 250 for the past 2 to 3 months. And we know it should be somewhere in the mid-100s. So this is such a great example. Why is this smart, wealthy gentleman with access to everything one of the worst controlled patients in our entire extreme makeover group? And that's really what it's all about, is turning this guy around. And it's all up here. You know, he never tested his blood sugar. And your home glucose monitor, at least when I talk to patients, is your own personal laboratory in the palm of your hand. Yes, no one likes to prick their finger, but there are better techniques, and this is information for the patient primarily, for the caregiver secondarily. Now, as someone living with diabetes, I don't like these advertisements, because why? They always show normal blood sugars. And I dare these meter companies to come up with a meter that looks like this. And then a little voice comes out and says, damn. Or, you know, they have little speakers, or at least program certain sayings, like, what did you eat this time? And my kid's favorite one, oh, that's why you're acting irritable, you know, and well, us diabetics, whenever we get irritable, someone says, go check your blood sugar. Now, I think it's important to realize that home glucose monitoring, at least for patients, you know, they're so used to saying, here, doctor, here's my logbook, here's my meter, just take a look scroll through the memory. You know, and that's not really the way it should be. It really should be that people living with diabetes, they need to know what to do with a number and then act on it, whether it's self-management because you've been trained to adjust your insulin or whatever, or at least if you're too afraid to change things yourself, at least call up your caregiver. Your appointment may not be for 3 months, but you're noticing a pretty significant trend of a high blood sugar at one point of the day. And let's talk about diet. I mean, there's no such thing as a diabetic diet. I believe in 2 to 3 well-balanced meals throughout the day, avoiding sugars and fats most of the time, sticking to your cultural and ethnic preferences. That's basically it. There's no magic diet out there. And, you know, all these marketing scams out there you see on television, money back guaranteed, you know, that really is one of my pet peeves for sure. And people are desperate. They fall for these things. There's no shortcuts. Weight loss is extremely difficult. You have to make small changes slowly and eat the foods you like in moderation. You know how that saying goes, we are what we eat? And I'm a big believer that we are not what we eat, we are how much we eat. So if you want a juicy, greasy cheeseburger once in a while, for God's sake, have one. You know, this is a 5-pound hamburger in Cincinnati, Ohio, and with French cheese on it, Velveeta. And if you eat the whole thing in 1 hour, you get it free. Now, if you use visuals like this in education, I mean, people can see how much sugar there are in regular foods. You know, I have patients that come in and say, Doc, I drink regular Coke. I just can't stand the taste of diet, you know, and I'm thinking, got to work on this person. And, you know, you can show them this visual. And I had a patient that tells me how great cinnamon is for people with diabetes. Anybody hear that? You know, I've eaten 2 to 3 Cinnabons a day. It hasn't helped my diabetes at all. So I think just to get serious, you know, I like to simplify things. I'm a very concrete thinker. You know, I think we need to think in bright colors when we eat. You know, fill your plate with green, yellows, and reds. It's as simple as that. Okay. And so I got the wrap-up time, so let me finish. What about exercise? Anybody see anything wrong with this picture? This is my elliptical stepper. I use it every day. And here, this is exactly how I use it. I'll be off in a second. So my other patient, I just want to tell you very quickly, she has type 1. She's now on all kinds of therapies, multiple daily injections, insulin, and her doctor didn't tell her about the different devices. Her A1C was high, and she bounced around like crazy. I got my 2 insulin pens right here. Didn't tell her about that. Didn't tell her about insulin pumps. I have an insulin pump here. I have one in my pocket. And I also have an Omnipod, which is stuck here. I colored it so you could see it. Got take off my shirt here in front of you. And just to show you that these devices can be pretty easy to use. And so I don't need 3 pumps. I obviously need 1. I'll button it up after the show so I finish on time. Okay, I'm going to finish up. Continuous glucose monitoring is key. This is a device that tells patients what their blood sugar is every 5 minutes. And this is a device that doctors don't tell their patients about. And that really makes me angry. This is what they look like. They're small, they're easy to use. I show that picture of me on there so that you guys realize that I am quite dope. All right, let me finish. This was Liz with her readings. She's all over the place. And when people say it's just diet and exercise, there's a lot of variables that affect your blood sugar. And that's important to know. It's not just diet and exercise, and there's a lot of unpredictability. And so this is her afterwards. Not perfect, but a lot better. And of course, I talked about hypoglycemia. Diabetics their whole life are trained to avoid complications, but you can die from low blood sugar. And this is Cindy Fina, who passed away from low blood sugar. So basically, in conclusion, I think, this is the little dog that you can train to pick up low blood sugars, service dogs. And you can have, and pretty soon they'll be on the CGM of our cars, our ARS systems. And this is Charlie Kimball, who was in the Indianapolis 500 with a CGM device taped to his steering wheel. Okay, I am finishing up. This is the Juvenile Diabetes Research Foundation. They're here to raise money and coordinate research. The Pediatric Diabetes Research Foundation, their center, they're here to become one of the best research and treatment centers in America. Under David Winkler's leadership, there's no doubt that'll happen. And I think the better model for education is the research and teaching institutions need to educate patients and physicians in parallel to create a better dialogue between themselves. Patients need to help their doctors take better care of them. Doctors need to be less judgmental. And lastly, these are the main themes of taking control of your diabetes. You have the main responsibility for taking control of your diabetes. You are your own best advocate. Be smart and be persistent. And at Taking Control of Your Diabetes and other organizations like the JDRF and ADA, we want to keep people healthy until a cure comes along. Thank you very much.